Here are some notes on bariatric procedures. There are two big buckets for bariatric procedures. The first is restrictive procedures, which reduce your stomach volume to limit your food or calorie intake. The two main types are gastric banding and sleeve gastrectomy. Gastric banding has an adjustable silicone band on your upper stomach. It creates a small 15 to 20 cc stomach pouch, and it has an adjustable port under the skin for band tightening or loosening. The advantage is that you have no permanent anatomical changes, and you have a lower risk for malabsorption complications. The other restrictive procedure is sleeve gastrectomy. This is depicted down here. This is also called a gastric stapling. You have a vertical stapling of the stomach, which removes the fundus and greater curvature, as shown below. The other big bucket is malabsorptive procedures. These combine gastric restriction with nutrient malabsorption. The main type is gastric bypass. The most recent, or the most common, is called Roux-en-Y gastric bypass. This creates a small gastric pouch by stapling or banding, and it connects the pouch directly to the middle jejunum. You bypass the gastric remnant and the upper duodenum. You have higher risks with this procedure. You have increased perioperative mortality. You also have B12 deficiency as a risk, anemia, and you can have staple line failure. Some common complications you can have in the short term: bleeding, wound complications, band slippage in the banding procedure, gastric leaks in the bypass procedure. In the longer term, you can have ulcers, strictures, ventral hernias, fistulas, severe reflux, small bowel obstruction, nutritional deficiencies, especially with the bypass, neurologic complications. You can get various neuropathies, band erosion, and gastric pouch perforation. Some modern trends: there's increasing use of minimally invasive techniques, laparoscopic and robotic approaches, smaller incisions, and shorter operative times with more experienced surgeons.